Hello and welcome everyone to this Reform webinar, Cancer Care, a Looming Crisis. Before we officially kick off the event and I introduce the topic and our fabulous panel for this event, we'll just wait a couple of minutes as more participants join this webinar. And in the meantime, we've prepared a little poll for you. So I can see the number of attendees popping up. And so we wanted to ask you actually the kind of £1 million question of how do you deal with the backlog? So obviously we've created a little poll, which I'm launching right now. I think as panelists, you can also vote on this poll, which you should see a little thing pop up on your screen and you can cast your votes. Of course, we've allowed this to be multiple choice, so you can vote for several of these options, as obviously it might not be just one single solution that might help. Great, so you're seeing the votes coming in, about 36%, 40% of votes have come in. It seems to be increasing the number of COVID-free cancer hubs in the NHS is quite the most popular answer up until now. And then the kind of second to that is extend contracts with the independent providers, but we've only have about 70% of votes that have come in, so I'll just wait a bit. And in the meantime, I do realize I have not introduced myself, so I'm Eleonora Harwich, Director of Research at Reform, and we will be kicking off the event pretty soon, just waiting for a few more of you to register and connect to the event. In the meantime, you can also admire the magnificent garden that Carol Sakura is sitting in. He was actually previously talking about the beautiful cucumber that he has, which is very, very proud of. And we're all very jealous. Okay, about 75% of votes. So for those of you just joining us, we have a little poll where we're asking you a kind of multiple choice question of how do we deal with the backlog in cancer care. You've got several options that you can choose. Again, it's a multiple choice. Great. So given that we have about 80% of the votes that have been cast, I will just end the poll here and share the results with you. So there we go. I'm sharing the results. So you should see another little window pop up on your screen, clearly showing that overwhelmingly you think that there should be an increase of the number of COVID-free cancer hubs in the NHS. That's interesting, and we will be discussing that once we reach that question in the panel. Second to that is actually investing more in diagnostic technology. And then as a number 3 is extending contracts with independent providers. So I will now stop sharing these results and then move on to introducing the event. There we go. So just as a little reminder, this event is being recorded and it will be available post event once we've kind of finished the editing. If you want to tweet about the event, the hashtag is CancerCare. So do feel free to tweet about it, as some people won't be able to join us today, and they might be able to kind of follow the conversation through Twitter. So obviously, as we know, it's no secret that coronavirus has unfortunately had a huge impact on the NHS's ability to carry out the activities that were part of its business as usual. This is reflected obviously in kind of recent data that shows a massive drop in hospital admissions compared to April of last year. So when you compare, April of this year to that of last year, and Carol, correct me if I'm wrong, but I think the drop in hospital admissions is around about 85%. Which is quite staggering. And actually, when you look at cancer itself, cancer care itself, it has been particularly affected by this pandemic. And obviously, despite having created these COVID-free cancer hubs, unfortunately, there has been a massive drop in GP referrals. And that's true for a lot of other health conditions, but particularly for cancer. So when you look at the cancer referrals from GPs, the drop is at about 60%. When you look at referrals for breast cancer screening, it's at about 78%. So obviously it's quite staggering figures. And we know also that people are waiting much longer than they would have for treatment. And so practitioners obviously have been sounding the alarm bell now for months. And these are some of the difficult and hard, I guess, truths and facts that we will be discussing in this panel, and as well as kind of most importantly, how do we move forward and how do we solve this? So to answer these questions, I have an absolutely fabulous panel with me with Steve Brine, MP, who's former Parliamentary Undersecretary of State for Public Health and Primary Care. We have Professor Carol Sakura, who's the medical director for Rutherford Health, and Linda Thomas, who's chief executive of Macmillan Cancer Support. And I will introduce myself again, just in case you didn't catch that. I'm Eleonora Horowitz, director of research at Reform. So what I will do now is that I will ask panelists to briefly introduce themselves and give your thoughts on the impact that the pandemic has had on cancer care and potentially any research that you've done in this area. So Steve, could I potentially start with you, please?
Yeah, thanks, Eleanor, and thanks for inviting me along, and hello to everybody who's dialed in. So I'm Steve Brine, the MP for Winchester and Hampshire. Since 2010, I was Parliamentary Private Secretary to Jeremy Hunt when he was Secretary of State between 2015 and 2016. I was a government whip from 2016 to 2017, serving the DWP and the Northern Ireland office, and then I was the Public Health Minister at DH, working to Jeremy, and then of course Matt Hancock. I was in that role from 2017 to 2019, when I and the government parted company over Brexit. But I guess I'm not alone there. So I'll probably just make 3 points by way of introduction. So number one, I think COVID presents a perfect storm for the NHS, and cancer services are pretty much at the eye of that storm. I think we have to be honest and say that the system was under considerable strain before the pandemic hit. Targets were being, not just in cancer, targets were being missed, and notwithstanding that cancer survival rates were heading in the right direction, and I was very proud of that. Waiting times were, for all the 9 cancer targets, among the lowest since the standards were introduced a decade ago. So, the pause button being hit has only made that more challenging. Point 2, referrals were obviously down, and Eleanor has said, we saw the NHSE stats last week, cancer referrals down some 60%. I mean, there's lots of attention here. It had lots of media coverage, and indeed the 60% drop figure is around urgent cancer referrals made by GPs in the month of April. But I think we should also bear in mind the drop in A&E attendances per se, which I think I'm right in saying we're down some 42% year on year to May. And I say that because it's not to say a huge amount of work isn't going on through our cancer alliances to face this, but too many cancers still identified for the first time in the emergency department. So the presentation drop in emergency departments could be an as yet unseen implication of COVID. And then finally, I just, I tried to be a half full person, and I tried to be a half full minister. We shouldn't over the next hour depress ourselves any more than is absolutely necessary. Lots of people who are relying on us, and so much me these days, but certainly Linda and Carol. Yes, there's issues around backlog, capacity, diagnostics, screening, particularly, but I think the structure we established is strong, and I think it's robust. I think we've got real grown-ups across what I used to call, when I was in the job, Team Cancer. So Callie Palmer and Peter Johnson steering the ship and pulling the system through this, the system, and the top quality people like Linda in the wider big society. And it's worth remembering that although obviously coronavirus has caused the postponement of some cancer treatments, which obviously weaken the immune system, which is partly why that happened. I think it's around 30,000 people still began treatment during March. So, and then the final point I would make is that we have opportunities from COVID around a very changed primary care landscape, and a renewed enthusiasm, I think, at the heart of government for the prevention agenda, which I'm passionate about, and I wrote the prevention part of the prevention green paper. So, to give you an example, about 90% of GP surgeries are now doing telemedicine. Before this hit, it was less than 50%. So actually, let's not be too doom and gloom. There are many opportunities out of what has happened, and I look forward to hearing the views of my fellow panelists and our guests.
Great, thank you, Steve. Carol, can I go to you, please?
Sure. Well, I'm Carol Sakura. I've been an academic oncologist for nearly 45 years, 40 years as a consultant in the NHS. So what's the problem and how can we measure it? We've heard some figures, so let's just repeat them because they're important. Diagnostic referrals. It's true that the total number of admissions have dropped by 85%. That means the NHS isn't clearing diagnostic work on hospital admission. As Steve said, A&E attendances have dropped by 50%. The 2-week wait referrals from GPs by 60%. Breast referrals by 78%. We know all this. Endoscopy, almost non-existent for the last 2 months. You just can't get an upper or lower GI endoscopy anywhere for whatever reason. So all this means the number of diagnoses of new cancer has dropped. Can you really find out a better metric? The best metric would be the biopsy numbers of malignant disease. So I tried to do this. I tried in 2 places. One, Imperial, a central lab at Hammersmith Hospital, and where I used to be full-time, and 2, a private lab in Harley Street. Both agreed that during the month of April, 8% of the normal biopsy turnover was received. Now, there was no way they could press a button on the computer, either in the private lab or the NHS lab, to tell me how many malignant samples had not come through. But they could tell me it had dropped to only 8% of what was normally expected in the month of April. So something is definitely going on, we know that. The third metric would be cancer registration, but that's driven by biopsy data, and that doesn't come for 3 or 4 months later. It's a fairly slow business. It doesn't have to be fast. There's no reason it needs to be fast. And then the final metric one can look at is radiotherapy and chemotherapy referrals, oncology referrals to an oncology consultant, whether they're radiotherapy, chemotherapy, or both. And collecting that data, there's such a lag in collecting it. So although there were no referrals for hospital admissions, we know that the data for the referral to a doctor for oncology care, it comes a lot later on. So we know there's a problem. The second problem is not just that there's been a delay, but also everyone's going to come at once. And the time they're going to come, I would predict, is later than we're really thinking. I think it won't be till somewhere at the end of July, August, that we'll start seeing a slew of cancer patients coming through. If you remember in April 8th, we saw the COVID demand for hospital services, and the NHS coped beautifully. At the peak on the 8th of April, it dealt with all the critical care. No one went without critical care. The Nightingales were a buffer, but were never really used. I know they opened, but that was tokenism, it's political display. There was no need for them to open, and the staff would have to come anyway from existing hospital systems, so it made no sense to open them. So what are we going to do with this backlog? The backlog is going to be the problem. And I think the questionnaire was good. And I have a 5-point plan, which is very simple, which more or less goes down that questionnaire. COVID-free zones, absolutely essential. The Premier League can do it. They've tested 3,000 players. They played 2 games last night, albeit without an audience. All were tested twice a week for the last 4 weeks. And only 10 people, staff and players, tested positive out of 3,000. So they took them out, told them to stay at home, and carried on. That was just a model system. Why can't we do that in the NHS? After all, we own the tests, for goodness sake. I guess there's not so much money to be made as in Premier League football. That's the real reason behind it. The second thing, monitor biopsy levels. We've got to get a handle week by week how many cancer biopsies are coming through. That will tell us when we'll get to the peak and will allow us to prepare for it. The third thing is use the independent sector. There are 26 private radiotherapy machines in a network All out, there are three main players in this. I know Rutherford is one, but there's Genesis Care, there's HCA, mainly in London. 26 private radiotherapy machines. They never work at full capacity because that's the way private medicine works. You get treated the next day if you want to. That's what you're paying for. Why not use them here for everybody? And there are 65 private chemotherapy places. That's without home care delivery. And there's more than just healthcare at home. There's a series of local delivery schemes out there. Just coordinate it. It needs to coordinate. And there is no coordination, I can tell you. I can see it now, even now. The fourth thing is coordination of services locally and abbreviation of services. Chemotherapy, radiotherapy, shorter courses. The college, the radiologists have been very good. They've issued new recipes for breast cancer and prostate cancer, which between them make up something like 40%, even 50% in some centers of workload for radiotherapy. If you can give hypofractionated schemes where you give 5 fractions rather than 20 fractions, you save time, you save money, you save footfall, you save infection risk. And then finally, I think the fifth thing is, what about extended hours? You know, we shut the radiotherapy departments at 6 o'clock around the country. This is crazy. We don't even open them even on Saturdays. This is crazy. These departments cost huge amounts of money. 52 radiotherapy departments in the NHS, 26 in the private sector. We've got enough capacity. We're just not using it properly. We've got to get better ways of working, and we have to pay for it. And that's really going to be the problem going forward. So my view is there is going to be a problem. It's going to be a short one. We've got to get back. Now, the doomsday scenario from the epidemiologists that's not spoken about because it might frighten people is that there's going to be a second wave 5 times the size of the first. This is going to hit in September. We're going into total lockdown. The NHS will be closed to everything but COVID again. All hospitals have been asked to make more critical care facilities. Thankfully, I think it's wrong, but it is being. You have to prepare for that. That would be the end of cancer for all patients this year. That would be a total disaster. I think we just have to plan to move forward without the second wave or with a minimal second wave and really go for cancer now. Otherwise, more people are going to die of cancer than ever died from COVID this year. So I'll stop there.
Wow, strong words to stop. Linda, please.
Yes, thank you very much indeed, and good morning, everybody. So, as you might imagine, Macmillan's focus during the pandemic has very much been on patients and the lived experience of what people have been experiencing over the last 3 months. So, I was really hoping that Carol was going to be throwing in some large statistics, and you haven't disappointed us, Carol, so thank you so much for that. So, I'd like to use this time to tell you one family story of cancer and COVID. So, meet Ruth and Andrew and their 2 teenage sons, and they look very much like any other family, don't they? But their story over the past 3 months has been very different to yours and mine. Ruth works for Macmillan in our fundraising team, and on the 4th of April, I received an email from her, and it said, "Last Wednesday, my husband Andrew and I had the earth-shattering news that he has bladder cancer. He's a fit and healthy 52-year-old, and this came completely out of the blue. To give him the best possible chance for the future, he was told that he had to have his whole bladder removed. Andrew and I have really struggled to come to terms with this operation, which will be life-changing for Andrew and for us as a couple." Ruth wrote, "We went to the appointment expecting to be given a date for surgery, only to be told that due to the virus, they could no longer offer Andrew the life-saving operation he needs. All cancer operations are being stopped in the hospital, keeping all beds free for COVID. The consultant did say they have no one in those beds at the moment." So over a period of 2 weeks, Andrew was then offered radiotherapy and chemotherapy. He was then told that the chemo wasn't an option because of the risk of infection, so it would have to be radiotherapy alone. Then they were told that he might need an operation later and that this would now be more complicated due to the scarring from the radiotherapy. So I hope I'm presenting a picture really of massive uncertainty and unease and anxiety for this family. By this point, Andrew's outlook had gone from an operation to cure him to a 20 to 30% survival chance with radiotherapy alone. They said that they were left angry and upset that Andrew's life was seen as less worthy than those with the virus. And let me just remind you, he's the fit and healthy 52-year-old. So I think at this point, the family decided that they were going to fight back, to be perfectly honest with you. They said it wasn't good enough and they asked for a review of his case. And then they received a call to say that the case had been reviewed and the operation was back on. And in fact, the operation went ahead and went well. But I wanted to just highlight that post-surgery support in the community has also been very different for patients over the last few months. So Andrew would normally have had a daily visit from the district nurse and the stoma nurse, but none of this happened. So he was taught over the phone to give himself injections and how to look after his stoma and his stage. For anybody that's been through that would really appreciate, that's really hard for a person that had no experience of that before. Anyway, the family muddled through. Friday, I got another email from Ruth to say that Andrew had got his results, and the good news was that the cancer hasn't spread and he doesn't need any further treatment. So she signed off by saying, "We are anxious, but very relieved. I am just glad we're made of stern stuff and have people around us who've supported us, and we have Macmillan to talk to. I don't know what we would have done or how we would have coped if we weren't made of Yorkshire grit." So with an expected, but we know now not delivered, 90,000 patients expected to be diagnosed during the last 3 months, this is not just one story, this is a consistent theme that all of our research at Macmillan Cancer Support has shown us. Half of patients have reported vital appointments and procedures being postponed, cancelled or changed. We're also hearing of loneliness and isolation, which has been hugely increased, not least for the 240,000 people who are currently shielding at home. Cancer waiting times, as Carol said, and as Steve referred to, which were 40% for April, 40% of people coming through the system in April that we would have expected. But even now, nearly 2 months on, we're still only at 60%. So we know that we do have a very big problem facing us. So like Steve, I'm a glass half full person as well. And I think I'd want to end by saying, I don't think that any of this is anybody's fault. We have been in the most incredible situation. And we also know, I know that my Macmillan professionals in hospitals all around the country have done everything they can to support people, as has the NHS. But I think it's really important that as Carol says, we do draw a line underneath this now, and we recognise that cancer had become the forgotten sea, and we really need to make sure going forwards that that isn't the case.
Thank you, Linda. Just as a small reminder to attendees, I know that we've been receiving already some questions through the Q&A chat, but just if you do want to ask questions to the panel, please use the Q&A function. We will be getting to those questions and answering them live at a later stage. So just to kind of finish on the numbers and facts and do the kind of current state of play. Carol, have you seen, I think, any kind of particular trends in terms of, are there particular areas of the UK that have been particularly badly affected by the backlog, or any types of cancer?
I think there's no real data. That's the problem. I mean, it's very interesting to see the breast, which is the number of breast referrals for urgent lumps. Basically, it's clear cut. The GPs, a woman with a breast lump usually gets diagnosed the first time they go to a GP, whereas if you have pancreatic or ovarian cancer, it may take 3 or 4 visits or even more before a referral is made. But so it's a very good test of how the system's working. And if those referrals have dropped by 78%, that's just a massive drop. So are we getting out of it? I don't think we are. That's the problem. I think Linda knows it too from things. I mean, 60% is not good enough for cancer patients. We should be up at 90% by now. Sure, the NHS is not fully recovered, but you know, the critical care units are empty. We're ready to operate. The surgeons should be ready to operate. You could query whether we have enough surgeons to deal with everybody coming at once. But you know, if we treated this as well as we treated COVID at the height, people were working 12, 15 hours a day for a short period of time. You could get the management doctors like me back into the chemotherapy units, and we could at least be the doctor there and check everything and so on. A bit of imagination is needed to get things moving, to stop cases like that. Like Linda, I've had friends of mine, 2 of them, close personal friends that were on chemotherapy. They were just sent an email to say it was stopping, and that was it, no discussion. And they sent it to me, and I said, just make a fuss. And they made a fuss, and they were back on chemotherapy the next week. And that's the problem. No one knows what to do. And people, the level of decision making is not at the top. very nice priorities from the top from NHS England, but it's the inaction locally that's not great. And that's what we've got to improve now.
Right, thanks. And actually, so I guess with the privilege of a bit of hindsight that we have now, what do you think the government could have done differently to ensure that we would have potentially tried to respond a bit more effectively to, I guess, the kind of two priorities, which is obviously trying to do the COVID response and a bit of the business as usual, and potentially would have been able to not disrupt cancer care as much? And Steve, I'll go on to you first, if possible.
Yeah, so when you say, you know, how bad is the backlog and types of cancers likely to be affected, I mean, I agree with Carol. It's almost impossible to answer, in that while we have some stats that were made public last week, you know, the greater threat, and I referred to A&E as one example, is that we don't yet know what we don't yet know. So you know, I referred to screening. I am very concerned about the big three screening programs, so breast, bowel, and cervical, which I understand, you know, they weren't stopped by central government direction, but they were more the individual centres making what I'm sure was a logical decision. You know, we know from last week, don't we, that the breast cancer referrals were among the hardest hit. Although they are firing up now, you know, given the numbers in these programs, in the breast program especially, it's going to be very hard to get such a large number through on top of the day job of those that were due this month and next month, etc. So, you know, I think in terms of your question about hindsight, what should have been done differently? I mean, crikey, where to start? I don't think a lot of the scientific community have covered themselves in glory with their ability to view things through hindsight in recent days. But I mean, look, going back to screening, I mean, the way the centres were literally all closed down, I don't blame them for that. As I said, they'll have done what they thought was best and in knowledge of their patients. Although I agree with Carol, I don't think that decision was a shared decision-making process with patients as much as it could have been. But I think it's fair to say that there could have been and should have been some national guidance from central government on what would have been right, so long as that had happened in consultation with the trusts around the screening centres. I think that is it is hugely regrettable the way that happened. There seemed to be a kind of all hands on deck fighting fires around COVID, which was understandable. But I do think there was a lack of national guidance from central government around the screening programs, for instance.
Right, thank you. Linda, would you have kind of any different views about what could have been done differently?
Yeah, I mean, I'm with Steve, first of all, right, to say with the benefit of hindsight is absolutely fantastic, isn't it? And I'm sure we would have all done things differently. So this is not about bashing anybody, but it is about, and I think it's really important, if we were to get into a second wave, we've got to learn from what we've learned last time and not make the same mistakes again. So maybe I wanted to pick up the issue of shielding. Actually, I think there has been some real difficulties for the shielding community. The lack of communications around that has been so profound for people being sent letters, then sometimes getting text or being missed off lists. And you know, back to Carol's point, we didn't even have data on who should have been on the shielding list. So there were some really mixed messages around that, but it affected 250,000 people living with cancer. I think we as cancer charities had to all get together to basically write to government and say, what are you going to do about this? And it wasn't until the 30th of May that actually a shielding letter went out to everybody. And that felt like a long time coming together. And I think there's just something here about going forwards. We really need some consistent messaging around shielding as well. It's not good enough just to say to people, don't go out indefinitely. There needs to be some more rationale, and perhaps linking up between hospital data and central data as well around who actually is on that list and what is it, and what are people being told, so that when patients get letters which are driven centrally, that we don't then hear that people's GPs haven't had access to those letters, for example. So I would definitely do something different on the shielding.
Yeah, I think that's a really interesting point, and actually relates to one of the questions that we've had from actually a couple of attendees, asking basically how do you deal with the fact that people have just been very scared to go into hospitals as well? And so kind of back to you, Linda, do you have kind of any ideas about how potentially, I guess, NHS England or the Department of Health are communicating about it, how to reassure patients to just not be afraid and actually be able to use the resources that are currently there?
Yeah, it's a really good question, and it's something that we picked up at the NHS England Cancer Board yesterday, actually. So I think everyone is acutely aware of this. Probably the most effective public health messaging ever was stay at home, don't go out, be scared, because and boy, it really worked, because people didn't realise actually that still vital services were there for them. I would like at some point, and even if we don't pick it up during this webinar, to acknowledge as well, I think there's been a very big issue from people from Black and Asian minority ethnic backgrounds. So some of the data is showing us that for some parts of the population, actually the not coming forward is even more acute for those parts of the population than it might even be for others. So I think people were really scared. We did as much as we could, and together with NHS England, midway through this, recognised that the numbers of people weren't coming through for referral, tried to put some remedial action in place around communications. But I think fair to say it's still a work in progress, and we were talking yesterday about the need for who do people trust, and how do you then get messages out? It's not necessarily charities, but it might be people living with cancer who can say, it's okay, I've been into the hospital. I heard this week from a woman who'd had 2 hospital admissions during COVID for her cancer treatment. She said it was absolutely brilliant. So it's about getting those messages out that it is safe, and that people can step forward. But it's not easy, and I think in all aspects of our lives, we are seeing people who are scared to do things. People don't want to return to work. People don't want to do all sorts of things. So it's not surprising they don't want to go to a place where they think there is the greatest risk of infection.
Yes,
but I would add to this about the public's scared. Yes, other than don't die of ignorance, stay at home,
of course,
protect the NHS and save lives is probably the most successful public health messaging of ever. But look, I'm on the Culture, Media and Sports Select Committee, and we were talking about a big inquiry we're doing about misinformation, disinformation around COVID at the moment. This may be controversial, but I happen to think that the media have a responsibility here as well, where they need to put their hands up. So take the issue of PPE. So in the area that I represent in Central Hampshire, which is Hampshire Hospitals Trust, we never once ran out of PPE. There were times when we were low on stock. We never once ran out. If you'd listened to the news, the broadcast news coverage, especially at the start of this pandemic, you would have thought that every hospital in the country was sending staff out to the front line with no PPE. And the public picked up on that message. And I, as the elected person on this panel, I had constituents coming to me saying, I've heard on the radio, staff are not protected, but the virus is rampant in hospitals, and we're terrified to go in there. And so, the truth was there was a massive problem with PPE, but it wasn't everywhere. There were problems in areas where they were incredibly acute and they were incredibly serious. And we've seen healthcare workers die as a result of their exposure to huge viral loads, but it wasn't everywhere. And the media never really made that clear. And I think they have a responsibility, and they should put their hands up when it comes to the inevitable inquiry about the way the public viewed the NHS throughout this crisis.
Yeah, it's really interesting because it just seems that you're kind of all in different ways picking up on a kind of almost like a crisis of communication and information sharing, because it ultimately is, we don't have the data to really kind of fully understand what's going on. We don't have the data to be able to kind of shield vulnerable communities in the best way as we possibly can, or at least we're trying, but we're finding issues with it. There's a crisis of communication with the public in terms of what they can do, but it's, I guess kind of really, kind of a hard message to kind of deal with. So I guess another potential point around that information and capacity to adapt and maybe kind of react to new information coming in. Once we kind of understood potentially that we weren't going to need as much capacity as we thought within the intensive care setting, the NHS didn't kind of fully adapt its plans in that sense and react to that information. I'm guessing understandably so because of the scare of the second wave. But I wonder if potentially it would have been feasible to divert some of that capacity towards the kind of business as usual again. So Steve, I'll kind of go to you first, because I know that you do have some strong views about this when we kind of talked about it, and then go to Carol.
What you mean on Nightingale, for instance?
Yeah, well, potentially that, or also even just within hospitals in certain local areas where they realise that they're going to get the same wave as London.
Yeah, so I hear this argument that, you know, Nightingale hospitals were a huge achievement, and they were a huge achievement, and you know, why couldn't we just put other hospital services in there, because that capacity is not being used. They were designed to be ventilated HDU units. They were not designed to be anything else. And actually, I think toilets was one of the biggest issues, in that they weren't set up for patients. And so the idea that you could just move hospital services into Nightingale, I think, was wrong. And I totally disagree with the idea that Nightingales were window dressing. They were most certainly not. I was involved in receiving some recommendations from the famed Operation Cygnus in 2016, which made a number of recommendations, one of which is that we prepare the legislation, which became the draft pandemic flu bill, which I was involved in drafting, which obviously morphed into the coronavirus bill and act that we then had to pass at speed. But one of its other key recommendations is that we should make sure that there is enough ventilator capacity in the acute sector, and that was absolutely the public's and the NHS's key priority, is that they should not be overrun, which is why the message said protect the NHS. Did you want to touch on the involvement of the private sector and the cancer hubs, Eleanor, or do you want to come on to that?
We can come on to that. We have been receiving questions. I guess.
Yeah, let's come on to that in a bit.
Yeah. I don't know if any of the panelists have a kind of slightly different view about capacity to kind of adapt to new information as it was coming in. Carol, I don't know if you have any different.
Yeah, I didn't mean that Nightingales were actually window dressing themselves, but the use was unnecessary. And now they've been put into storage, which is the right thing to do in case there is a problem over the next few months. I don't think there will be at all, but the problem was always going to be to get staff for them, because where do you get them from suddenly? We're short of NHS staff anyway. You've got to move them in. That was the problem. I think, how do we get out of this is the key.
Yeah.
And I think that's really what we need to, how can we get moving again? And there is this culture of fear, as Linda says. Everyone is so scared. I travel around our centres by train and I get a whole carriage to myself, and there's no food on the trains. You can't get even a cup of coffee, or you can on Avanti, the West Coast main line. They give you a cup of coffee. So it's great. But people are just too scared. They're too scared to go to the doctor. And so they'll suffer symptoms for longer, and that's the current problem still.
But so what are kind of your top 3 recommendations to kind of deal with the situation and deal with the backlog, which I know is the kind of £1 million question that I will put to all of you. So Linda, Steve, do prepare while I grill Carol on this question.
So I have my 5-point plan, which is more or less following your question there. I think the most important thing is to say COVID is over and just get services back to normal. We've got to get rid of the 2-meter distancing. It's never going to hold. It's not going to hold anywhere. These sort of things are not based on science. The WHO never said we needed 2 meters. They stuck to 1 meter. If we get to 1 meter, we can run the clinics easily. If we have 2 meters, we have these ridiculous things. I went to buy a newspaper this morning. You have to stand in these 2-meter queues. It's just ridiculous, and it is such nonsense. And what you have to do is not let people that have got a fever come into your shops or to your cancer centers, and you've got to take them off. Have someone at the door screening people with a thermometer. It's so simple to do. There's all sorts of things that we've got to do, some of them political, which Steve has to do through his offices, and some which is just sensible medical, and some which is very much the people, which is what Linda Macmillan Fund, tremendous brand name that people trust. And I think to use this to try and persuade people that they've got to get, if they have problems, they have to get them solved. Don't just expect them to be solved for them by the state. They have them. If you've got tummy ache, get it sorted out.
Right, thank you. Linda, I'll go to you.
So I think, like Carol, you know, we've all got our 5-point plan. The charities have come together. We've devised a plan. We've written to the Prime Minister about that this week, actually, and we want to see some urgent action as a result of that. It still feels like there's an absence of a coordinated plan to get us out, which sounds really boring, I know, but actually it's kind of like, wouldn't it be great if we had one and everybody knew that's what we were working towards, so we could all work as one system? I mean, I have no doubt that there's a lot of people thinking about this. I liked the 4 things at the beginning. My thought was we need all of them and more, actually. And I do think, you know, coming out of this, there's some really interesting opportunities for us to do some different things. So right across the country, and I'm sure everyone has seen this, we've seen things move to online services or telephone services in a way that we might never have thought possible. So whatever we do, we mustn't put back in some of the bureaucracy that we had in the past that was slowing stuff down, because everything needs to be speeded up going forwards. I think it's vital that we get the diagnostics sorted. That's a key thing that we have to get, because clinically that's the most important thing that will make the biggest difference to people. A worry that I have in us doing that is that we lose some of the personalisation agenda, which is really important for people. So the things which we might think are nice to have, like the communication, like the chatting to somebody, like being able to see somebody face to face, for example, we need to be careful that we don't just play into a world where people like us who are really comfortable on Zoom get everything we need, but other people don't. Somebody said to me the other day, all crises leads to inequalities. We've already got inequalities in cancer care. We know that. We need to make sure that gap doesn't get bigger through this as well. So I think somebody needs to have a lens on that, look at that as well.
Yeah, that's really interesting. Actually, you're picking up on one of the points that was raised by one of the attendees to this event, which was exactly that point around inequality and how do we make sure that actually it's not something that is exacerbated when we kind of move on and try to understand what's next for the NHS. So Steve, I'll go to you. I don't know if you have a 5-point plan or a 2-point plan, or what are your ideas to get out of this?
10 points. I mean, I think it is around confidence. So I think from an economic point of view, you know, this is not 2008. This is not a credit crunch. There's a huge pent-up demand. So we've got to make people confident that they can go and spend in the economy. I think that confidence issue is the same in healthcare. So, you know, I think it does come down to these COVID-safe cancer hubs. I think, you know, back in March, as part of the plan, which we wrote, you know, the NHS secured pretty much all independent hospitals across England as part of their capacity for cancer, so for NHS cancer and the urgent surgery stuff. So in my area, you know, people on the call will know Sarum Road in Winchester is doing all of our oncology work, and they're COVID protected cancer hubs, but they're not just with the independent sector. That added capacity, and I think, you know, where they were established early, and they were in the part of the world that I represent, I think they're maintaining a good percentage capacity, which has been important, and they'll be important going forward in pent-up demand. So I was lobbied very hard by my trust around the extension, which was due to end, the deal with the private sector was due to end at the end of this month, and that's now been extended into the autumn. I think that's very important. I mean, others on the call will be able to know how well this is going across all of England, but I would just flag this, that despite the COVID protected hubs being set up, I think there is concern, this is the confidence point, that patients are still at risk of infection from asymptomatic healthcare workers and other patients. So, you know, the government announced last month, didn't they, that all medical staff will be tested weekly, and that all NHS staff and patients will be eligible for this antibody testing. And that's important, and will become even more so as the lockdown measures are relaxed further. So I think we do need confirmation from the government that testing is happening at the pace and scale required. And the former Secretary of State, now the Chair of the Health Select Committee, Jeremy Hunt, my old boss, raised this in the House yesterday, actually, during an urgent question to Matt Hancock. And, you know, I know this is something that CI UK, for instance, have written to Matt about as part of, I think it's called Safe Spaces for Cancer campaign. And I know they're on the call as well. So I think that the safe space cancer hubs are going to be really important. And I hope that with that arrangement across the public-private, I hope we have put to bed this public good, private bad dialogue nonsense that we hear in the House of Commons way too often, and realise that actually Team Cancer goes across all parts of the healthcare sector, and the third sector, such as Macmillan, who, let's face it, they have done an incredible job. They're doing basically more with less because they've had a bigger demand on their services and they've received a lot less in the giving, I suspect, that they would, because events have been cancelled. Linda can talk about that clearly far more than me, but I suspect that is something that occupies a lot of Linda's worry time, is that they're being asked to do a lot more than less.
Right, thank you very much. So we have a very vibrant Q&A, actually, with about 30 questions that we need to go through. So what I'm going to try and do is basically kind of put them together and then kind of direct them to you. So we've actually received a fair few questions asking us, how do we deal with obviously the kind of challenges of restarting at least surgery within the cancer care pathway, given not only the backlog, but as we kind of mentioned as well, the issues with workforce and all of the kind of issues that were existing before in cancer care. So Carol, could I go potentially to you for that question?
Yeah, so that is one of the biggest challenges. Radiotherapy and chemotherapy is very much downstream in the management process of a cancer patient. And we're ready. I mean, we heard about private sector, public sector. The departments are not busy anywhere in the NHS or in the private sector because no patients are coming through because of the problem with surgery and the lack of biopsies. So that's where we've got to put the first hit team, if you like, to solve it. And how we solve it, well, we've got to get business as usual. We can do the referrals by Zoom. That's not a problem. The patients go to see a surgeon. They need to have the relevant bit of the body, the expertise for the relevant bit of the body. The surgery has to start. The operating theatres are empty. The critical care units are now empty. Most of them have been cleared totally of patients with COVID. We have to create these COVID-free hubs and move forward. And I think the private sector has been involved in that and at a local level, and that's how it has to be. There's no point saying, oh, we're going to send all the patients with colon cancer to a private hospital in the Midlands, for example. It's got to be a local coordinated approach because it's the same doctors, it's the same surgeons that work traditionally in the private sector as work traditionally in the NHS. There's not a different team. So they've got to coordinate how they work. And I think it has to be done locally. That's the only way it can be done, or regionally, I mean, a big locality. And then the patients will start rolling through to the cancer centres. And then we can look at how we can get the private radiotherapy services involved and the private chemotherapy service and the home chemo services. So I think there's a sequence of events. How we solve that surgery problem, I don't know. And I'd be interested to anybody's ideas on that, especially the surgical teams. They have to come to their own conclusion.
Well, so attendees, if you have any ideas, please put them in the chat. We will look at them. I don't know, Linda or Steve, do you have kind of any ideas as how we might go about it?
Well, I don't think it's about. I mean, look, we're just the panel. There's far more expertise in your task list. I mean, you got the director of clinical research at the Royal College of Surgeons across England, who I remember talking to well. They will surely have a view, but it has to be about capacity. Because I know productivity within the NHS is way, way down because the sheer level of carefulness they have to go through in the post-COVID world. So it has to be about capacity. But bring on the Royal College. Let's hear from them.
Great. So the message is out. We will wait to hear from the Royal Colleges. But actually kind of talking a bit more potentially about the opportunities and some of the things that we might be able to use in terms of, different types of technology or what the role of technology might be to actually help with this backlog. Do you see, I guess, kind of any interesting applications that you've seen at this point in time, or any things that you think would potentially kind of drastically change, even, I don't know, say maybe something that would be able to deal with some of the kind of workforce or expertise issue that we might be able to kind of spread across as maybe kind of, doing remote kind of surgery and all of those things. So I don't know if they're kind of any.
I don't know about surgery or not, but I mentioned at the start, didn't I, about primary care. And when I was a public health minister, I was also the primary care minister, and I remember talking to people in primary care who some would say, well, minister, this very brave minister, people don't all want to have telemedicine. People want to come in and basically we've redesigned primary care at the start of this in about the space of 3 weeks in my area. And it's been remarkable how, you know, as I said, over 90% of GP settings now have the ability to telemedicine. And if you look at the faster diagnosis standard that we put in the long-term plan, rightly so, you know, I was talking to the Secretary of State just last night about the 75% ambition of diagnosing cancer stage 1, stage 2. You know, that is still absolutely mission critical for him and for me. And, you know, we put that in a long-term plan for a reason. But if we're going to get to the faster diagnosis standard, then we have got to make sure that we maintain that use of technology across primary care, across the RDCs, and we haven't even talked about the cancer alliances yet, who have got to continue to identify through their local organisations how they can put that diagnostic capacity in place, because we got to be picking more up, and that's before we even get to prevention.
Right, thank you. Linda, yes, please, sorry.
So I'm with Steve, actually. I think there have been some stuff that we really need to now just see universally rolled out, and not just go back to old ways of working, but actually this is the new normal, and how do we do it, and you know what they are. There's a whole range of things, but an observation I would have is we shifted all of our direct services at Macmillan to remote working within 24 hours. That was something that it would have taken us 2 years to have done, probably, you know, between everything, 24 hours. And actually what we're now seeing from people is that at least 50% of staff are saying they never want to go back to the office. What the opportunity that has given us is that we no longer need to recruit specialist people, whether they're welfare specialists or health specialists, from just a narrow range of geographies. Suddenly the whole of the United Kingdom, and potentially the whole of the world, is open to us from a recruitment perspective when people are suddenly remotely based. So I think there is some acceleration of things around that. And certainly I was thinking in terms of the diagnostic capacity and triaging patients, for example, because one thing's for sure, we can't keep seeing the same number of worried well people. We really need to get quite quickly, when people come forward for diagnosis, to people who really need that care and support. So it's how do we build those types of remote working models where we could be having better triage systems for people in advance of people then having to actually be able to go to somewhere like an RDC, for example, and free up that capacity to help people who, well, the people who really need it, actually, rather than the people who think they might need it, but after a short conversation it would become clear that they might not. So, you know, I guess the caveat on all of that is there are risks to doing this, and there are risks around the types of people who readily engage with technology and the types of people who don't readily engage with technology. So there's a bit more data, back to data again, required to make sure that the unintended consequences, which nobody would believe would happen, you know, that we mitigate against that. And there's a route for people who still want to be able to go down perhaps a more traditional route, and for whom it might be impossible, not that they don't do that. So, but there are great opportunities.
The point is, Linda, isn't it, is that primary care's problem has always been the sheer numbers coming through the door you referred to.
Yeah.
That was when I entered DH, I asked the special advisors, you know, what should be worrying me most on my desk, and they said that the you know, capacity in primary care. So you know, if primary care has less coming at it all the time, it can focus more on, as you say, on those that it needs to make that decision for around picking up cancer, because that's people's interaction with the NHS. Most people's interaction with the NHS is through primary care. And I would love to see, I also had the privilege of being the pharmacy minister, I would love to see pre-primary care, as I called it. So the pharmacy, which is, you know, some 11,000 NHS badged premises up and down the country, on the high streets up and down the country, completely underused as a diagnostic tool. And they are health professionals in their own right, and we completely overlook them at the moment.
And I think, if I may, this is the most important device. You know, everywhere, from the poorest countries in the world to the richest countries of the world, the smartphone has such potential for healthcare delivery and for cancer care delivery, both in the diagnostic phase and in the treatment phase, and for healthcare messages, public health messages, and we're not using it. I think that's the one good thing that come out of COVID. Now, I really take what Linda says. Older people, myself included, struggle sometimes. I find I get stuck with it. I probably use about 10% of its function. I just can do a few things I have to be shown how to do, and then I'm okay by my kids. So that's the problem with this. It's age related. It's actually cheap. You know, what amazes me that the whole telephone systems in third world countries are run by cell systems rather than landlines. And so it's very effective. What we've got to do is to go for those groups that find it difficult because they're elderly, because they're confused by it, because they just can't work the technology, and show them how to do it and give them essentially technical counseling from an organization like Macmillan to bring them into the new cancer plan. I mean, it always amazing. I used to run the prostate clinic at Hammersmith. Week after week, I have about 30 elderly men would pitch up and with their prostate cancer simply for follow-up. And that could have all been done down the line with the GP taking blood for the PSA, and so the marker for prostate cancer. And, you know, there was waste of their time, well, not a waste of my time, but it was a waste of their time making the journey, often 2 or 3 bus routes to get there, the whole day just to come and see me for 10 minutes. Whereas we could automate it in a way that would be satisfactory. And that's what we've got to go to, I think. And this has given us the kickstart to doing it.
Yeah, so Linda, a very short comment because I'm quite conscious of time and we still have quite a lot of questions to go through. And yeah, please.
Can I just put a shout out for the workforce here?
Yes.
I think as well, if we're expecting workforce to behave and do things differently, we really have to look after the workforce in the NHS. And actually there's a real need then for training of professionals in a different way, making sure people are equipped with the skills. I don't know about anybody else, but the first few weeks working from home on a 10-hour-a-day Zoom call was a nightmare, and I felt exhausted in a way that I didn't previously to that. I can't imagine what it's like if your life in the NHS is breaking bad news to people and you're doing that remotely. So I think, you know, we do need to really support the cancer workforce through all of this.
Yeah, thank you for that shout out. Actually, maybe to kind of finish us off on a kind of more positive note or outlook. I guess obviously this has forced quite a lot of new ways of working, as you've kind of mentioned. And what would you like to see moving forward, at least of what has been done in kind of recent months? What would you like to keep? What would be your kind of coronavirus keeps? And also,
well, Linda referred earlier about some of the bureaucracy and red tape. If you talk to, I was speaking to the Secretary of State about this last night as well. I talked to staff in the NHS. They say actually, because we've released them from some of the bureaucracy and some of the form filling that they had because we had to, and they say, you know what, you trusted us to do our jobs and to get on with doing our jobs, and we really liked that, and we need to see more of that. And you know, it'd be very odd of me as a former Minister of Prevention if I didn't say this. So 2 things. One is that I said at the start, there is a new appetite, I think, within government around prevention. We have gone from so-called sin taxes, as they were called once, to a new belief in tackling obesity. And you know, I brought in the sugary drinks in levy, and huge amount of work went into the prevention green paper. I look at the risk factors that we know around COVID, and the sad thing is that COVID won't be the last. There will be another coronavirus, and we need to be better prepared as a population, and that is around prevention. And we know that obesity is one of the greatest risk factors to developing a cancer, and we are going in the wrong direction on obesity. So we need to be bolder and much more interventionist as a government, and it is an issue and an agenda that I'm going to be pushing during this Parliament. The other side of things is that, and Linda rightly said this at the start, as you would have expected her to, is that the emotional side of the cancer journey, as Kelly Palmer used to say to me when I was in office, is that, you know, it's no good us improving the survival rates for cancer if the quality of life that you survive to is rubbish. And I completely agree that the quality of life that you survive to has got to be excellent. And that is about, yes, obviously the right health outcome, and the sooner you get it, the more likely you to do that. But the emotional side of the cancer journey has been hit so hard during this crisis. People haven't had the support groups that they would have. And you know, somebody who lost a parent to cancer just before Christmas, I know the support groups that they were able to access that he wouldn't have been able to access if that had happened during the last few months. So the emotional side of the cancer journey is absolutely critical. It's not just for solid tumor cancers, but you know, you look at the blood cancer journey. Yeah. People live on the watch and wait for years and years, and actually, you know, the emotional side of that I know takes a huge toll. I suspect Linda's had a lot of that through her door, in the last few months.
Thanks, Steve. So if I could go to Linda and Carol, just last few words. What are your kind of corona keeps?
definitely all the stuff that related to technology, I would say. So in two areas. One would be the telemedicine that's been used by clinicians to be able to support people. Where that's worked, let's keep it. Let's stop people going into hospital if they don't need to for results, for example, and things like that, if that's not necessary. I think the other thing is big shout outs to trusts and teams around the country who have set up services that used to happen face to face remotely, absolutely brilliantly. And that is everything from yoga classes to peer support groups. And surely going forward, there's going to be a way for a blended model around that, actually. So, you know, really recognizing people have been really very, very great at setting these things up.
Great, thanks, Linda. And Carol.
So the last I can think of, I've read some very interesting books over the last few weeks, especially about past pandemics, the ancient Greece pandemics, the cholera pandemics, that led to a lot of healthcare facilities. It led to the creation of my college at Cambridge, my old college in 1342, the medieval plague. So good can come out of these things, but the one consistent feature about all the plague stories through medieval Europe, even in the 19th century, was they only end when people have the confidence to say they're over and carry on with their normal day-to-day business. And that would include, in the context of cancer, the treatment of cancer. So we've got to get that confidence back everywhere. And everyone's confidence has been shattered. The politicians, the doctors, everybody, healthcare staff, the charities, we've got to get back. And the sooner we can get back, the less patients with cancer will have an unneedless decline in their survival potential. So that would be my message. Let's get back to normal.
Great. Well, thank you so much. This has been such a pleasure to chair this panel. So kind of in summary, we have a 5-point plan of Corona Keep. So obviously slightly less bureaucracy and red tape to be able to kind of drive innovation. We've mentioned prevention as the kind of future forward agenda. Potential of telemedicine and actually kind of remote working and technology in general, having confidence and obviously not forgetting the difficulties of the kind of emotional journey of cancer and being able to support people in a kind of very human way. So thank you so much to our panelists for giving up their time and joining us to this really interesting conversation today. Thank you so much to the attendees who have sent us so many questions, and I really do apologize that we didn't have time to go through all of them, but thank you so much for having participated. We will be doing an event tomorrow as well at Reform, so do tune in for that one. And one last kind of plug for Reform is that we will be releasing a paper looking at the question of how do you build resilience in the NHS, and that should be over the next kind of couple of weeks. So do check our website for announcements. But thank you so much to everyone. Thank you. Bye.
Thank you.
Bye.